Good morning, everybody. Welcome to our event. We're so excited to have you here today. My name is Patty Taylor. I am the Director of Quality and Patient Safety at the Dallas-Fort Worth Hospital Council, and we are your hosts for today. Super excited to have everybody here, and especially our guest speaker from Region 6 CMS office, Tiffany Curtis. We're so excited. I want to really thank the Regulatory Collaborative. They are the ones that brought this to you. We are going to try to do more of these throughout the year. So anybody who is on today's in-service, we will make sure you get notifications for future ones. We are recording this session. We will post the recording on our website, and we will be able to share the slides. Thanks to Tiffany being so generous about that. We appreciate that. There are no CEs for this today. When we do in-kind in-services, CEs are just a little too expensive for us to offer at that time. So at this time, I would like to introduce Tiffany Curtis. She is a Texan transplant by way of Virginia. She received her BS in nursing from Hampton University and her MSN in community and public health from the University of North Carolina at Charlotte. She started in CMS in 2016 as a long-term care surveyor and is currently a nurse for the acute and continuing care branch. Prior to starting with CMS, Tiffany worked as an intensive care nurse for 13 years, and in her spare time, she likes to travel, cook, and read. Tiffany, I'll turn it over to you now. Thank you again so much.
Hello, everyone. Once again, my name is Tiffany Curtis. Patty, thank you for the introduction. I am part of CMS Dallas, the acute and continuing care branch. My team includes Dodjie Guioa. He's our lead. I'm sure many of you know who are very familiar with Dodjie. Also part of our team, Marcus Foster, Dorsey Sandunji, and our manager, Karen Hillman. It is an honor to present, and I hope that these topics are informative and provide some insight. Give me 1 second, and I will get this started. Okay, so before we start, I would like to just clarify some things. CMS survey, this term, for the sake of this presentation, CMS surveys are surveys related to the investigation of the federal conditions of participation, also known as COPs. They are investigated by the state agency, CMS contractors, or CMS federal surveyors. This presentation is related to federal regulation. Texas state regulations tend to be more rigorous and may trigger investigations or surveys in addition to the federal regulations. So I can only provide direction to federal regulations. In 2019, CMS reorganized. What was previously known as the Dallas Regional Office is now CMS Dallas. However, you may still find the term regional office or RO in the state operations manual and other regulatory documents. Okay, so let's begin with part 1. What triggers a survey from CMS? Many people know CMS provides coverage to our elderly and disabled. In addition, we provide oversight for compliance with Medicare health and safety standards for acute and continuing care providers. Surveying providers for compliance is one of the ways we provide oversight. Part of being a certified CMS provider is complying with the federal conditions of participation. COPs are our standards described in the Code of Federal Regulation and State Operations Manual. This certification is usually done by the state agency, in our case that would be Texas HHSC, on behalf of CMS. However, a facility may choose to be deemed by an accrediting organization, also known as an AO, instead of being certified by the state agency. An AO has authorization from CMS to inspect a facility to determine if they meet the federal COP standards. If the facility meets these standards, they will receive a deemed status. Being deemed is a voluntary process, and some examples of AOs are the Joint Commission, DNV, and HFAP. Deemed or not, any Medicare participating facility can be investigated by the state agency if there are allegations of substantial noncompliance with the federal regulations. These survey inspections for determination is usually done by the state on behalf of CMS. The function that the state performs for CMS can be found in Section 1864 of the Social Security Act. These are our federal COPs. There are approximately 17 of them. As you can see, it covers just about every function of a hospital. There are additional COPs for psychiatric hospitals that I did not list, but these involve special provisions, medical records, and special staff requirement. I also want to review there are two types of deficiencies. You can have a standard level, which means that the deficient practice has been identified, but is not substantial, or you can have a condition level. This means a serious deficient practice has been identified and is not in substantial compliance within that condition of participation. Common CMS surveys. Complaint surveys, they are allegations of substantial noncompliance. The complainant, if verified and uncorrected at the time of the survey, would result in a condition level deficiency citation. You have full surveys after a complaint survey. These surveys are after a complaint survey is found to have condition level deficiencies. CMS may authorize a full survey after the complaint survey. A full survey involves all COPs investigated. And we also have EMTALA surveys, Emergency Medical Treatment and Labor Act. This applies to all Medicare participating hospitals. EMTALA requires hospitals with emergency departments to provide a medical screening examination to any individual who comes to the emergency department and requests such an examination, and prohibits hospitals with emergency departments from refusing to examine or treat individuals with the emergency medical condition. So a walkthrough of the complaint authorization process. The SA or state agency, they receive an allegation of substantial noncompliance. The SA submits the request to CMS for approval of the complaint survey. We receive the allegation and we determine if the allegation meets the criteria to investigate. Then we will authorize the state to conduct the survey if needed. I would like to point out, if CMS does not feel the allegations meet substantial noncompliance, we will not authorize the state to investigate those federal COPs. EMTALA has a similar process as well. I also want to stress, if your facility is deemed and the state receives a complaint with potential substantial allegations, CMS must review the allegation and approve or disapprove for investigation. It does not matter if your last AO survey found no deficient practice or a few deficient practice. If you are a Medicare program, if you're in the Medicare program and you're receiving payment, and if there are substantial allegations of noncompliance related to one of those COPs, your hospital may receive an investigation regarding that COP that may be in a deficient practice. So, what to expect from a CMS survey? I would like to reemphasize that CMS surveys are surveys related to the investigation of the federal COPs. They may be investigated by the state, CMS contractors, or CMS federal surveyors. For the sake of this next topic, I will be discussing what to expect from a full survey. Many of you are familiar with full surveys that have been completed at various hospitals across the state. Many of these hospitals had a prior complaint survey that determined condition level noncompliance. And based on those findings, CMS Dallas determined a full survey would be the next best step. Full surveys at large hospitals need a lot of surveyors, and it is a collaborative effort. Sometimes CMS federal surveyors would join the team to be an additional surveyor, training purposes, or we may be present to be additional resource and/or support to the state or hospital. The state typically leads these surveys, but whoever is the lead for the survey will let the hospital leadership know. We understand that this is a stressful time. We are stressed just as much as you are at times. However, we can channel this stress into positive energy to get the survey done and complete and that it's efficient. So I would like to just provide some tips for you and your hospital on how to get through a survey. First thing is an entrance conference. This is the formal introduction of hospital leadership and the survey team. Entrance conference should involve all key leadership individuals of the hospital that are present. This is usually the first thing that we like to do as soon as we enter and announce that we are here to do a survey. We like to meet with leadership and just go over the purpose of why we're here. Some key leadership are not physically present in the hospital. We understand, that's no worries, but I would like to encourage that you go ahead and proceed with the entrance conference, and whomever is missing at that time, if you can just give them a brief update on what's going on, and we can make a formal introduction of that missing person and the survey team once they are present and make sure that the questions are answered. During the entrance conference, the purpose of the survey and the COPs being investigated are explained. Surveyors usually give an estimated time it will take to complete the survey. But mind you, this is estimated time. It's not going to be a guarantee. Items that are needed immediately, room assignment for the surveyors to work, and requests for staff that can assist surveyors during investigation may be discussed at this time. There should be a Q&A available to the staff. There should be a clear understanding of the immediate next steps from the survey team and hospital leadership. If there is any doubt, any clarification, maybe you misunderstood something, maybe we've already explained it and you just want us to repeat it, do not be hesitant to ask. We want to make sure that you and your staff know what's going on and what are the next steps. what to expect with day-to-day activities. This is definitely a all hands on deck situation. We're asking that you please have adequate amount of staff to assist the surveyors. Non-clinical hospital staff should prioritize their duties during this time to assist the survey. Surveyors should be patient with hospital staff assisting them. Please encourage your staff to be patient with the surveyors as well. Surveyors should provide staff a list of requested documents with the priority of each one. If the surveyor does not have a due date when that document is needed, please clarify the due date. We don't want the surveyors sitting, waiting on a particular document while hospital staff may be producing another document that the surveyor may not need for another day or two. So it's very important to have this priority date or when these documents are needed, so that way we can get the survey moving along and the investigations completed. As the surveyors are wrapping up investigation of their assigned COP, it should be a clear understanding of preliminary findings among the surveyors and hospital leadership, department leadership. End of the day meetings with team lead and designated hospital leadership should occur. These should be brief updates with progression of the survey deficient practice that may have been identified and highlights of the day and possible plans for the next day. And of course, if there isn't any deficient practice that has not been identified at that time, they can provide an update regarding that as well. The facility should have a designated contact person for the survey team lead. If this is a large hospital, surveyors usually need escorts. It doesn't take much for us to get lost. Surveyors need a direct contact person for the COPs that they are investigating. Surveyors should be communicating their plans for the day with the staff escort and or direct contact person. This may change. Please be flexible and patient with us during this time. Staff leadership should decide if it is okay for their staff to exchange numbers with the surveyors to facilitate communication. This is not required, but I have found in the past, if I'm out on a survey and I may have requested a document and I realize maybe I no longer need it or I need something more specific, I can just shoot a text to that person instead of having someone, pass a message, can such and such come to the room or things like that. A lot of times it just saves time and it just helps facilitate clear communication. I also want to point out a lot of large hospitals, but the surveyors, sometimes they have a scribe and an escort. From our standpoint, it really doesn't matter if you have a scribe and or escort. We just need someone that's hospital staff that's been designated to be a contact person with us that can escort us around if needed, help us arrange interviews with the staff, tours, etc., things like that. How many people you want on this team is ultimately up to the hospital leadership on who goes with the surveyor. Do not assume. If you do not understand what's going on, please ask for clarification. There's no such thing as a stupid question. Please just ask if you don't know what's going on. Do not assume. It's A-okay. Please be transparent with surveyors during the investigation. It benefits you more than you know. If there's a sensitive or delicate subject that needs to be discussed privately, that's not a problem. Just ask to speak to the team lead. Whoever you need from your leadership side can come to the meeting, and this can be dealt on a private manner with the next steps. If a surveyor is requesting a policy or procedure that does not exist, just say so. Just say you don't have it. Please don't try to create one at the request of the survey team. Exit conference. The exit conference is a summary of preliminary findings noted during the survey. There should be no surprises of these preliminary findings. Any findings should have been previously discussed among surveyors and the department lead and hospital leadership. Preliminary findings are subject to change, and also it should be discussed what to expect post-survey. Surveyors observe the right to refuse an exit conference if the facility is being represented by counsel at the exit conference, and anytime the hospital creates a hostile, unsafe, intimidating, or inconsistent with the informal and preliminary nature of an exit conference environment. Surveyors may refuse to conduct the conference if the lawyer is trying to turn it into an evidentiary hearing. Your hospital counsel can be present, but you cannot be solely represented by the counsel, and the counsel cannot try to turn it into an evidentiary hearing. So, in summary, CMS surveys are investigations of federal COPs that have been authorized. The goal of a hospital survey is to determine if the hospital is in compliance with COPs. Deemed facilities are subject to CMS surveys. EMTALA applies to all Medicare participating providers. Common surveys include complaints, full surveys after a complaint, and EMTALAs. If surveyors are on site during a survey, it still may be a state-led survey. The team lead for the state and CMS will notify administration which agency is overseeing the survey. The stress is acknowledged among all persons involved with the survey. We've discussed the purpose of the entrance conference. Staff availability to assist is vital. Daily meeting with the team lead and leadership to provide progress of the survey should be expected. The importance of communication among the hospitals and surveys is vital. Do not ever underestimate it. It is the key. I cannot stress this one enough. And your exit conference should involve preliminary findings and post-survey expectations. Surveyors have the right to refuse exit conference under certain circumstances. I wanted to just provide some useful resources for hospitals. It will be the State Operation Manual. Chapter 2 involves the certification process. Chapter 5 is the complaint procedures. Appendix A is the survey protocol, your regulations, and interpretive guidance for hospitals. And Appendix Q are core guidelines to determine immediate jeopardy. I did not want to provide a link to these documents on purpose. CMS periodically update these documents, so I would recommend just doing a Google search. Usually those are the latest documents that are available. If you do choose to download it, they're PDF files. Just note that there are no page numbers on them, and just be mindful of when you download that document, because you may have to go online just to do a search to make sure that there isn't a more updated chapter or appendix that you may not be using at the time. So I wanted to provide my contact information for myself and my team. I highly recommend that you contact me via email versus a telephone. That's the easiest way to get in touch with me. Once again, the hospital team includes Marcus Foster, Dorsey Sandunji, our lead, Dodjie Guioa, and our manager is Karen Hillman. So that is it with my presentation. However, I did receive some questions I would like to review. If you give me 1 second, I'm going to pull them up. Some of the questions that were received to me prior to this presentation, I may have already addressed during this presentation, so I may not go over all of them. However, if by the time I go through the questions that were received, if you feel like your question wasn't answered, feel free to provide the question to Patty. So the first question I received: what are the top items, themes that would trigger a CMS survey in addition to EMTALA, infections, or staffing issues? I feel like I've covered this question with my presentation regarding those COPs, but just to be a little bit more specific, sometimes we get allegations of abuse and neglect that will fall under one of our COPs. So that would be a very common allegation that could possibly trigger an investigation. The next question: what would be some infection control concerns / items that may or may not have been implemented by a system to manage COVID-19 that would trigger a CMS survey? So we have provided continuing guidance among management for COVID-19 and infection control concerns. So I would say that you should refer to the QSO memos that have been released by CMS and also go by the latest CDC guidance. The latest CMS memo I can tell you right now would be QSO memo -21-08. It's dated December of 2020, and it is the revised COVID-19 focused infection control survey tool for acute and continuing care. But essentially, if you are following the CDC guidance and the guidance that's coming from CMS, you should be fine. It shouldn't be any additional triggers. How many findings during a joint commission survey triggers a CMS survey? Is there a total number, or is it the risk level of the total number of findings that trigger? So if you are a deemed hospital, unless that accrediting organization is on site doing a survey and they find immediate jeopardy, and the immediate jeopardy is still present at the time of their exit, that's going to be the only way that's going to trigger a CMS survey or a survey involving the federal COPs. Has CMS resumed survey activity? Yes, we have. Can findings from a complaint at the state level trigger a CMS survey? The short answer to that would be yes. Many state level, or maybe what you could be considering state level, may already be federal COPs that are being investigated. However, it just depends on what the allegations are. Like I said, Texas tends to have a more rigorous, stringent set of regulations versus CMS. So it could trigger a CMS survey or a federal COP survey, or it may not. It just really depends on what the allegations are. I have one more question, and I'm going to actually hand this question over to Dodjie. So Dodjie, the question is, can you share information that you may have related to the pilot that CMS and Joint Commission did together in relation to partnering during hospital surveys? Has the pilot ended?
uh, the data for the pilot surveys hasn't been analyzed or tabulated at this point in time. I'm not sure we will continue doing a joint surveys with Joint Commission. That was just a trial uh, run and see how effective it is, to have a joint survey rather than EO is doing one survey and federal and CMS is doing as is another survey. We are trying to see if it can be done together, which means is that essentially CMS survey eventually, if the state is going to do a survey at a DIM facility, that the Joint Commission or any AO may decide to go ahead and join them, and so that the hospital, assist will have, one survey period, one stressful moment, assist, rather than two separate stressful moments. So I don't know what, assist, the outcome will be if we are going to, um, assist, develop a process, assist, that will implement a joint survey, because it has to be, it will take a lot of coordination between state surveyors and joint commissions. And we've done this in the past, but assist, actually, we, assist, we were going on site to a big hospital in Albuquerque, and assist, Steve Misenko in Joint Commission called me and asked, they received the same complaint, and they asked if we're planning to do a survey. And so I says, yes, we're planning to do a survey. And, I says, this is an unannounced survey. And so Joint Commission said, we know that, as we adhere, as we abide by that unannounced survey at all times. So if, as we would like to join your surveyors, as at the same time, so that we are looking at the same thing and we are coming into same conclusion, for what we are seeing at the same time. Fortunately, I was, I took two of federal surveyors to join the state surveyors. So I was able to facilitate that joint survey together. And we look at the same documents, and we do joint interviews with staff, we do joint observations, and it worked very well. And at the end, Joint Commission and the state CMS survey team came to the same conclusion. So that hospital only had to put up one stressful moment. And, there was another one in Texas where it was, again, I was part of the survey and we were already on site, and Joint Commission surveyors arrived. And of course, they called the people in Chicago, and they were instructed to see if Dodjie was on site. And if Dodjie is on site, to talk to him. And so they did. And we, we did again, a joint survey, and it worked very well. So, if that can be done, the thing is, there's a lot, there's a lot of things that need to be hashed out, and we have to establish, a policy and a process how we can coordinate joint surveys. So, that's all I can tell you right now is that we don't know where the pilot surveys is going to lead us to. I says I'm hopeful that it will lead to a joint surveys between EOs and the state agencies, because then says there will be says there will be no differences in the survey findings, where the EO finds there's no issues and the state or the federal survey finds there are big issues. So that's all I can tell you right now, is that uh, we don't know what's going to happen, with the pilot, with the result of the pilot.
Thank you, Dodjie. Patty, are there any additional questions?
Yes, there are some questions in the question box. If anybody has questions, you can type them in there. It's sort of, and I'm not sure if you answered it. I think you might have, but Dodjie, we received a state and joint commission complaint simultaneously. How are decisions made on who will visit the organization to conduct the investigation?
Okay. If the complaint was sent to joint commission and also sent to the state agency, then either or both can do the on-site survey.
Thank
So
you.
if the allegation meets the definition of a substantial allegation of non-compliance, which means that if the allegations are proven to be true, there will be a condition labeled non-compliance cited, then most definitely the state agency surveyors will be on site. Whether the joint, the accrediting organization will evaluate it as such is beyond our control, and whether they're going to go on site to do the survey, it's their decision.
Thank you. There is another question. Are COVID-specific surveys still occurring at this time since prevalence is declining within the state of Texas?
Okay. I was just in conversation with Steve at the Texas Hospital Association this morning about that issue, about whether hospitals are still being surveyed based on, because the governor has lifted the mask mandate and because the COVID rate is declining. And the answer is yes. Surveys for infection control will continue, until such time that CDC and our folks in Baltimore decides that it's no longer necessary, because the COVID rate of infection and positivity is going down. But my impression is that it will continue until such time that the pandemic is over.
Thank you. And there's one more question. How often are hospital licensure surveys conducted? They know initials are conducted, but what is the frequency after an initial?
Okay. We're not going to talk about licensure surveys, because that's the state survey authority, because they're just doing compliance of the hospital on the state regulations. For federal surveys, for Medicare surveys, the hospital, once the hospital has been certified by CMS based on the initial survey, Medicare survey done by the state agency, then technically the recertification survey should be done between 3 to 5 years. So,
Thank you.
yeah, that's the recertification survey frequency, for hospitals.
Okay, I believe that answered the question. At this moment, we have no more questions in the chat. Last chance for the audience to type in a question. I don't see anything else coming in. So I want to end this by saying thank you very much. It was very informative, educational. We really appreciate the time that you took to share with us. And again, to thank the Regulatory Collaborative Committee at the Hospital Council Foundation who asked for this to be done. And you might be hearing from me again throughout the year because we might be tapping into your resources. We really do appreciate the collaboration we have with you. We in the Dallas-Fort Worth area are very lucky to have you guys be able to be reachable. So we really appreciate it. Everybody, I will send out an email by end of tomorrow with the link for the recording and the slides. And so we just really appreciated everybody joining us today. If you have any follow-up questions, let me know. They were so generous in offering their emails too. We really appreciate that. And I hope everybody has a wonderful rest of your day. Thank you, Tiffany, Dodjie.
Thank you.